Thank you, everyone, for joining us today. This is Cindy Groniger at CancerBridge, and in a few minutes, excuse me, we will be joined by Dr. Amy Kerger. Before we begin our presentation, I wanted to provide a brief overview on what CancerBridge is, how it works, and how to contact us. Sorry, I'm having a little difficulty with my slide. I apologize. But what CancerBridge is, it's a cancer-focused navigation service provided by your employer that provides immediate one-on-one personalized access to a physician who is an expert in their specific type of cancer. Our goal is to provide immediate expert guidance at a time of uncertainty. CancerBridge is also, thank you, CancerBridge is also extended to immediate family members. The benefits that you and your family receive include someone knowledgeable who will listen to your questions and concerns, rapid access to an expert physician in their specific cancer, and enables you to obtain a broader understanding about that specific type of cancer, provides guidance on next steps as well as avoiding mistakes in navigating through the healthcare system. We strive to provide immediate answers during a time of crisis for you and your family members, as well as provide resources to go beyond a cancer diagnosis or care questions. An example is today's webinar, as well as genetic counseling, nutritional guidance, and other resources. Immediate family members include your parents, parents-in-law, spouse or partner, siblings, and children. Through the benefit that your employer provides, each of these individuals would be eligible to contact the CancerBridge service, no matter who their insurance carrier is. If you have any questions about eligibility, please contact your HR team. You might be asking, why can't your doctor provide the service? Cancer is a very complex disease with over 200 types of cancer. If you are being seen by a community cancer doctor, they are generalists with a basic knowledge of common cancers, but not an expert in a specific cancer. CancerBridge allows you the opportunity to speak to a cancer expert invested in one of your specific cancers. Our cancer experts know all the presentations and the latest best treatments for that specific cancer. The expert evaluates and treats only patients with that specific cancer. And our experts advise community oncologists on specific cancers as well. They perform and publish research, lecture around the world, teach medical students, residents, and fellows about their specific cancer field. And our experts know and network with other experts across the world in that specific cancer. CancerBridge is very simple to utilize. You or your family member, no matter where they are located, can call into CancerBridge and speak to an oncology nurse who will triage the call. That nurse will arrange a call with one of our cancer experts, typically within 24 hours. After a call with the expert, the nurse will follow up within 24 hours to make sure all of your questions have been answered. There is no limit to the number of calls you or your family member can make to speak to an oncology nurse or a cancer expert at CancerBridge. To learn more about CancerBridge, please visit mycancerbridge.com or contact your HR team. Before I turn the presentation over to Dr. Kerger, I wanted to run through some logistical aspects about the webinar itself. If you have any questions that arise during the presentation, please ask them via the questions box in GoToWebinar, and we will run through them after Dr. Krieger's presentation. If anyone has questions after the webinar or we will have run out of time, you can email questions@mycancerbridge.com and we will get your questions answered for you. A recording of the webinar will be posted on YouTube in the next few days. You will receive an email with a link to the recording, so please feel free to share the link with anyone you think would benefit from the webinar. With that, I'll go ahead and hand the presentation over to Dr. Amy Kerger, who is an assistant professor and breast radiologist with the Stephanie Spielman Comprehensive Breast Center. She will be talking to us on dense breast tissue and the impact it has on detection and prevention to breast cancer. Thank you, Dr. Kerger, for joining us.
Thank you, Cindy. Hello, everybody, and it's nice to be with you on this morning or afternoon, depending on which time zone you're in. We're going to talk a little bit today about breast density and why it's important and what you need to know about it. Disclosure, I don't have any financial interest or other relationship with any commercial organization that may have an interest in this content of this presentation. The objectives today for our discussion are going to be to discuss what breast density is and its risk, to discuss the current state laws, to discuss what breast density and the laws mean to you, and to discuss current clinical recommendations and the use of supplemental screening. So first, let's start out by just talking about what is breast density. What does that mean when we discuss this? So the breast is made up of two components. It's made up of fat, and it's made up of fibroglandular tissue. The fibroglandular tissue is made up of terminal lobular units, ducts, ligaments, and other supportive fibrous tissue. The terminal lobular units make the milk if a woman were to get pregnant. The ducts deliver the milk to the nipple so that the baby can receive the milk, and obviously ligaments and other supportive connective tissue help hold the breast together. All of these things in the fibroglandular tissue are what, when we look at a radiograph, appear white. The fat in the breast appears black or radiolucent on a mammogram. So when we are looking at a mammogram such as this breast here would be considered non-dense. You can see all this black or light gray portion of the breast is all radiolucent. That means that this is the fatty portion of the breast. The white portion, as you see here on this breast, is the fibroglandular tissue, along with some other vessels and things running through here. On this breast that is labeled dense, you can see there is some fat in this breast just along the edges and kind of interspersed between all of this white tissue that is the fibroglandular tissue. So I think a picture is worth 1,000 words as the difference between a dense breast and a non-dense breast, and we'll discuss what that really means to us. So as a radiologist, when we read a mammogram, we always put in whether one of these 4 categories for what the breast density is. It's part of our dictation. It's part of the current law if you have that law in your state right now. So here's an example of going through some pictorial examples of what these descriptions mean. So just like the picture I showed you earlier that was in the non-dense category, this breast would be described as fatty replaced. It's mostly fat with just a little bit of fibroglandular tissue. Scattered fibroglandular designation would mean you have kind of half fat, half fibroglandular tissue, so it's kind of a mix, 50-50 of those two elements. When we get into heterogeneously dense, now you're getting more of the fibroglandular tissue, the white part, comparatively to the fat, the black part. So this is getting to be denser. And then when we get into extremely dense, we have a lot more fibroglandular tissue ratio than we do to the fat. And so that would be considered extremely dense. So when we read your mammogram, we're going to give the breast one of these designations. So in the population of women, you're going to have 10% of women are going to be in that fatty replaced category. 40% of women are going to be in the scattered fibroglandular category. Another 40% of women are going to be in the heterogeneously dense category, and only 10% are going to be in the extremely dense category. The heterogeneously dense and the extremely dense category, squared here in red, make up what we consider dense breast tissue. So 50% of the population is going to be considered to have dense breasts. This slide we're going to come back to in a little while, but I just want to briefly mention it here and have you keep this in mind. When we're looking at mammograms, we look at sensitivity when we do research. So sensitivity means how likely are we to find cancer in this breast on the mammogram. So in a woman who has an almost fatty replaced breast, the mammographic sensitivity is 97 to 98%, which is really great. We find 97 to 98% of the cancers that would be in the breast on mammogram in someone who is fatty replaced. In someone who is extremely dense, the mammographic sensitivity reduces down to 30 to 48%. This meaning mostly masses. Calcifications and architectural distortion, which also can denote underlying cancers, are more easily seen with no matter the breast density. However, masses can be hidden when we get into more dense breasts, and so that decreases the sensitivity of the mammogram when you have dense breasts, especially in the extremely dense category. When we read your mammogram and we put those designations on there for the heterogeneously dense breast category, you will also see right after we say this breast is heterogeneously dense that it may obscure small masses. Most big masses we'll still see with the heterogeneously dense breast. With the extremely dense breast, you'll see after that designation, this may limit the sensitivity of mammography, as I just discussed. It decreases the sensitivity a lot comparatively to the fatty replaced breast, and it is harder to even see larger masses, sometimes with an extremely dense breast. So there are certain factors that can affect breast density. Some of the main things that decrease breast density are age. So as we get older, physiologically, our breasts should become more fatty replaced with time. Now, that doesn't happen with everybody. There are women who are in their 80s who have still very dense breasts and have no reason, aren't doing anything to have increased breast density. So, not everybody follows the physiologic things that are in the medical text. However, the average woman, as we get older, our breasts will become more fatty replaced. The fibroglandular tissue will involute because we aren't having periods anymore. We're not utilizing the breast to get pregnant and make milk. So those tissues will kind of involute and you'll be replaced with fat. Also, if you gain weight, that will decrease the breast density. If you are put on tamoxifen because you have had breast cancer, that also will decrease breast density. Things that increase breast density are weight loss, exogenous hormones such as Premarin, Provera, taking estrogen or progesterone for any reason can increase your breast density, and then lactation. So after, during pregnancy and after pregnancy while you're breastfeeding, the breasts are much more dense. There is research going on out there to find out more reasons why, why people have increased and decreased breast density. I've read some things that diet may hold some factor in the breast density, but nobody's come hard and fast on what portions of the diet, what can increase your breast density with what you eat and what decreases it. Obviously, the weight gain and weight loss portion of this, gaining weight just to decrease your breast density is probably not a good idea, because weight gain, also obesity, is linked to many other problems such as other cancers and diabetes and many other things. So, weight gain is not the preferred way to decrease breast density. If you have dense breasts, you have dense breasts. It's part of who you are, and it may decrease as you age. However, it's just something to be aware of, and I'll explain why here in just a moment. So as I said, breast density is not a fixed entity either. So, as we talked about, as you age, sometimes your breasts will get less dense in most people. If you take certain things such as the exogenous hormones or you get pregnant, your breast density will change. So year after year, you may not get the same letter. One year you may have you may not have a dense breast letter saying that you have dense breasts, and the next year you might. That can change with if you've lost weight or you've gained weight. The other thing is that the interpretation of the mammogram is subjective. So we're really good at inter-observer reliability for the fatty replaced and the extremely dense breasts, which are on the opposite ends of the spectrum. But the scattered fibroglandular and the heterogeneously dense kind of vary between radiologists. Some patients' breasts live on kind of that edge where you could go either way. Because of this, there is software being developed to kind of provide some objectivity to help us better, say, okay, yeah, this one is this is scattered fibroglandular, this is heterogeneously dense. But don't be concerned if one year you get a dense letter and the next year you don't, because your breast may have changed, or you may just have, breasts that kind of live along that line where for some people they're going to call it dense and the other people are going to call it non-dense. So you just need to be made aware that you probably fall in a denser category if you're getting a letter one year and not another year, and then next year you get a dense letter. And so you probably need to be aware of the fact that you may have denser breasts than the average population. Risk factors. Breast density is considered an independent risk factor for breast cancer. Now, compared with other risk factors for breast cancer, breast density is pretty near the bottom of the list as far as concerns. It denotes a very small increased risk for breast cancer, but it is something that if you know about, you can be more cautious with. So it's why we want to talk about it and why we want you to know you have dense breasts or you don't. So here's an example of the breast cancer risk factors. So number one risk factor for breast cancer is just being female. The rest of these risk factors that I'm going to go through are in no order of how concerning they are or not. Another risk factor for breast cancer is increasing age, genetics. 5 to 10% of breast cancers are hereditary, so they'll have a gene mutation such as the BRCA1 or 2 mutation. With that, keep in mind, most people who get breast cancer, most women that get breast cancer don't have a genetic mutation or do not have breast cancer that runs in their family. So that's only 5 to 10% of the population. Previous chest wall radiation during the ages of 10 to 30 can increase the chance for breast cancer. Personal history of breast cancer, proliferative lesions with atypia, which is a high-risk lesion that can lead to possible breast cancer in the future. First-degree relatives with breast cancer, meaning a sister, a mother, a father, a brother, a maternal grandmother can kind of fall into that, or paternal grandmother. So dense breasts, which we just talked about, when it says 1.2 times the relative risk for the heterogeneously dense, and then 2.1 times the relative risk for the extremely dense, meaning the heterogeneously dense category has a lesser risk than the extremely dense category, but still both of them have a little higher risk than just the average population when you add that up. Race and ethnicity, benign proliferative lesions, early menarche if you're before age 12 before you start periods, or late menopause where you go through menopause after age 55, and then lifestyle. Hormone replacement therapy, which is what HRT is designated for, obesity, though I just told you that if you gain weight that your breasts will become less dense, but if you are overweight you have an increased risk of breast cancer also. Greater than 1 alcoholic beverage a day, and then smoking should also be on there. These risk factors together, all combined, can be very concerning. So even though increased breast density denotes a small increased risk for breast cancer, combined with many of the other ones can add up to a greater risk. So that's why we need to be aware of all of the risk factors. The other thing that increased breast density does is something we call masking effect. So it will decrease the mammographic sensitivity like we had spoken about earlier. So the greater the density, the less chance we have of seeing these things on mammogram. We call this superimposition. So if I take you, a 3D person, and I compress the breast into a 2D picture, sometimes the more tissue you have, it can cover things up, and that can hide an underlying cancer. So with something over top of it, I may not see that cancer, but when I move that off of the mass, I will then see the cancer. So the greater screen basically you have over this, the less chance you have of seeing it until it gets larger. So that's another reason why the denser the breast is, the more reason you should know about it, because it can cause a masking effect on a mammogram and decrease the sensitivity of your mammogram. Here's an example. Here's a side view of a breast in a woman, and this is the ultrasound picture of this black portion here that has all this shadowing is a cancer. This is a cancer tumor, and that actually lives right in here. Believe it or not, though, you would not be able to tell this area of the breast from this area of the breast from this area of the breast and denote that there is a mass in there. So this is an example of the masking effect. With the denser breast tissue, it just was able to hide this tumor. So as we discussed before, and I said I would come back to this particular slide, the person with the fatty replaced breast will have a 97 and 98% sensitivity on the mammogram. This mass right here would have been seen in a breast that was just fatty. But a patient that has an extremely dense breast has a 30 to 48% sensitivity on the mammogram because it's just a lot easier for that cancer to hide, which is another, probably, in my opinion, a larger reason to know that you have dense breasts because of the decrease in the sensitivity of the mammogram. Where did the breast density legislation start from? It began with a patient in California. Her name was Dr. Nancy Capello, and she began the legislation action because in 2004 she was diagnosed with breast cancer after a mass was palpated on a clinical exam. She had a mammogram and it didn't show any findings to correlate with that palpable area. But then an ultrasound was performed, and there was a mass in there that was biopsied and found to be malignant. Despite all the years of screening, and she did annual screening, she was unaware that she had dense breasts, and that was associated with a decrease in mammographic sensitivity and a small increase of relative risk for breast cancer. So she felt that women should know about this, and that if they have dense breasts, it should be something that they can be proactive about. So she tried to put through breast density law, and she's been very successful. Currently, there are 27 states that have mandatory breast density notification laws. I am in Ohio, and we are one of the states that have this. I did a lecture a couple months back, and there were only 26 states. So currently, there are constantly new states being added to this list. Patients are required to be supplied with some level of information about their breast density after their mammogram in the states in which this law is present. State laws do not dictate, though, what patients are told, how you're informed. There's really no standard from state to state on the verbiage that is given to you. Currently, and this is something a lot of people don't know, currently there's only 5 states that have a state insurance law requiring coverage of supplemental screening for women with dense breasts. So that meaning in 22 states, there's no law saying, okay, I told you you have dense breasts, and you talked to your doctor and you guys said, oh, I probably need some more screening. Well, in none of the other states is there any law saying that the insurance companies have to pay for that supplemental screening, so that may come out of your own pocket. Even though those 5 states that do have the law, it's not necessarily applied to every single insurance policy within the state. So there's only a limited number of insurance policies that this law affects. So here's an example of places in the U.S. that have the breast density law. The states in hot pink here have the breast density law notification already enacted. The states that are in purple here suggest that they notify or educate patients. States that are in blue currently have an active bill that are to legislate breast density notification, and then the states in the yellow have an inactive bill. So at some point they had a bill, but it's no longer active. And then the states in gray have not introduced a bill at all. And the states with a little diamond-shaped black marker here are the states that have the insurance coverage law. So Ohio was the 20th state to enact the law, and our notification began in March of 2015. And when we send out a letter to patients that have dense breasts, this is what is written at the bottom so that the patient knows that they have dense breast tissue. It says, your mammogram demonstrates that you have dense breast tissue, which could hide abnormalities. Dense breast tissue in and of itself is a relatively common condition. Therefore, this information is not provided to cause undue concern. Rather, it is to raise your awareness and promote discussion with your healthcare provider regarding the presence of dense breast tissue in addition to other risk factors. So what does that mean to you? First thing it means is, yes, you have dense breasts, and that's very common. As we said, 50% of the population has that. So what should you do with that? You should go talk with your primary care physician and say, I got a letter saying I have dense breasts. I know that this is a slight increase in risk factor, and I would like to take a look at my other possible risk factors for breast cancer and make sure that we don't need to do any more supplemental screening. Currently, if you have 20% or greater lifetime risk of getting breast cancer, then we definitely encourage supplemental screening. We'll talk about that in a minute. So you want to talk with your doctor and make sure there aren't any other risk factors that you or your physician was not made aware of, or that having this dense breast, even though it's a very small relative risk, that it doesn't kind of push you over that limit that we need to do some supplemental screening. So what do you do if you have dense breast? If you do not have dense breast, then you just get your routine mammogram. And if tomosynthesis is available, which is a 3D mammogram, which I'll go over in a moment, you should accept that in combination with the 2D imaging, because it does help, and I'll explain why in a moment. If you do have dense breast, you should still get your routine mammogram, because mammograms are the only screening exam that we have that we know decreases morbidity and mortality from breast cancer. So that's been proven in the research. So you should also then discuss your risk with your doctor and identify if supplemental screening is needed. So let's talk a little bit about supplemental screening and the things that are out there that can add to the 2D mammogram to help better evaluate your breast for breast cancer. So there's tomosynthesis, otherwise known as 3D mammogram. There's MRI. There's whole breast ultrasound. And there's molecular breast imaging, otherwise known as MBI. So with supplemental screening, currently the guidelines that are supported by the American Cancer Society, the National Cancer Coalition Network, the American College of Radiology and Society of Breast Imaging, the American Society of Breast Surgeons, and the European Society of Breast Imaging look like this. If you're low risk, you get a 2D mammogram. If you're intermediate risk, you get a 2D mammogram. If you're high risk, which is over that 20% lifetime risk, then you get a 2D mammogram plus an MRI. But you have to be over that 20% lifetime risk to get the MRI. You can have an MRI anytime you want, but a lot of insurance companies, unless you prove that you're over that 20% lifetime risk, will not do a screening MRI and pay for it. So right now, currently, as the recommendations stand, density is not really a factor in the recommendations for supplemental screening. So here's that same kind of chart in a different format. So what should we do about that? So there is some research going on out there discussing maybe we should be looking at whether people get supplemental screening not only by their risk factors, whether they are low risk, intermediate risk, or high risk, but also what is their breast density and how does that change what we should do. The only thing that people are definitely in agreement is if you're a high risk, you should get a 2D mammogram and an MRI, no matter your breast density all the way through. So let's talk a little bit about tomosynthesis. Tomosynthesis, if you go in and get this 3D mammogram, you're going to get the 2D mammogram, and then you're also going to get the 3D mammogram. The machine looks exactly the same. You're going to be positioned exactly the same. To the patient, most patients say they don't even really notice a difference with the tomosynthesis than they did with the regular 2D mammogram. So you as the patient are probably not going to notice much of a difference as far as what you go through. What it does for us, the radiologist, is it takes a couple extra pictures and it cuts the breast into 1 millimeter slices for us, almost like a CT scan. But the beautiful thing with tomosynthesis is the radiation dose is a lot less than CT, and it's only slightly more than the 2D mammogram. The radiation exposure is equivalent to a 3-hour flight if you were going to get on an airplane. So it's very minimal increased radiation risk. It's actually, around the idea of maybe a chest X-ray or a lumbar spine X-ray. So, not too much more. But however, there is new software that a lot of people are starting to utilize, and we are supposed to also be getting here at the James Cancer Hospital. That will take the 3D images and it creates the 2D image from the 3D images. So instead of having to take the 2D mammogram and the 3D pictures, we can just take the 3D pictures, and that actually puts the dose right back down to the regular 2D mammogram, and there's no increased risk at all. So, like I said, tomosynthesis should be done in conjunction with the 2D mammogram at the time of screening. It also can be done in the diagnostic setting if it wasn't performed in the screening setting. It detects 1 to 2 more cancers per 1,000 people. It has proven to have a 40% decrease in recall rate, meaning when you get your mammogram and we call you back to get more pictures, a lot of times that is just because, like I said, you're a 3D person and we're putting you in a 2D image, and sometimes things line up differently, and it turns out to be what we call summation artifact, which is just that the tissue lines up and looks different than it should, and we want to go in and we take a couple extra images to kind of squish that particular area, make sure there's not something hiding under there, and if it's just regular breast tissue, then okay, great, and if there is something, then we can go on to do some more testing. But through the use of tomosynthesis, we've decreased that recall rate by 40% because we've gotten rid of that summation artifact, because we can see through the 3D person in a 3D image. So that helps decrease your chance of getting called back for something that's really nothing. Many insurers are now covering the tomosynthesis. Right now here in Ohio, I'd say about half the insurance companies are covering it. But for those that aren't covering it, the out-of-pocket cost for tomosynthesis is a lot less than whole breast ultrasound or MRI. So it is still at least affordable, but I think with time here in the next year or two, I think most insurance companies are going to cover this as a screening test. So it is a good option for you if you have a dense breast letter and even don't have a high risk worry such as a 20% or greater lifetime risk of breast cancer, that you still can get this and it will be covered, or if it's not at a large expense to you, to just put your mind at ease. So here's an example I'm going to try to give you of a tomosynthesis. This is a 2D mammogram of the left breast seen from the top to the bottom of the breast, so we're going from the head to the feet. And I'm going to play you the tomosynthesis. It's a little video clip. Let me kind of get out of this and pull up my video clip here. So as you watch the video clip run, it's going to kind of sweep through the breast. It's kind of fast, so we'll sweep through it a couple times. So as you watch, you can see kind of the changing of the tissue. As we get to the end, you can see these little black dots here that show up. That's the skin, so that's on one end of the breast. The other, we're going to play it here again. You can kind of see us go through the nipple and then back again. And we're able to see a lot more when we do this. So I'm going to play it one more time, and there actually is a little mass hiding in there. And then we'll go back to the 2D image, and I'll show you where it is, but it probably was not something that caught your eye. So here is that mass right there in the breast. That really pops out with the tomosynthesis for us. It also helps us know where in the breast is exactly located. If you saw this on my computer screen, it would give me a good location so we could go with ultrasound and see it better. So here's that 2D image again, and here it is hiding in here, but as you can see, it could be hiding in that tissue a lot easier. Now that I pointed out, it's obvious, but when you're just looking at this quickly, it probably looks no different than a lot of this other tissue sitting around here. So that tomosynthesis image is able to pull that out for us and help us see that better, to find those things. So let's talk a little bit about whole breast screening ultrasound. There's two ways this can be performed. It can be automated, where there's just a large probe that kind of comes down over the breast. It's set on the breast, and the machine just runs and it takes ultrasound images. Or it can be handheld, like if you've ever had an ultrasound of anything, you've gone in and had the technologist holding the ultrasound probe and scanning. So there are two different ways. Not a lot of people have the automated whole breast ultrasound, so if that's something you are interested in, you'd have to call around and talk with people, but it is out there and it is approved for use. But like I said, whole breast ultrasound, most insurance companies are not covering. The pros for this, for utilizing whole breast ultrasound, is there is no radiation exposure. It's well tolerated, and breast density does not mask any findings, so it doesn't really play a factor with ultrasound. But the cons for whole breast ultrasound is we get a lot of false positives, meaning we find things that either we have to follow for a long time, so you have to keep coming back every 6 months for 2 years for ultrasounds to double check this thing. It turns out to be nothing, or we find something that we need a biopsy that turns out to be benign. So there are a lot more false positives with ultrasound. The cost, like I said, is not covered by insurance, and you need about 234 screening ultrasounds to detect one cancer. You need about 127 mammograms, that's 2D mammograms, not 3D, and you need about 68 screening MRIs to detect one cancer. So you need a lot more ultrasounds to detect cancer than you do the other imaging modalities. Breast MRI, it has a very high sensitivity but a low specificity, meaning it pulls out things that are there and we find them. However, it's not very specific necessarily for cancer, meaning we do get a lot of false positives with breast MRI too. We find things we have to go back and we biopsy and turns out to be benign. So though it does find a lot more cancers, as I said, it only takes 68 of these to find one extra cancer. It does find a lot of other stuff too that is benign, and we end up biopsying or following up. Currently, breast MRI is only indicated for high-risk women who have greater than a 20% lifetime risk or newly diagnosed breast cancer. But in the screening realm, it's only if you have 20% more or greater lifetime risk. And you can find out if you have that kind of a risk factor by talking with your doctor and discussing the other risk factors you may have. And if your physician feels comfortable, they can utilize the risk assessment programs that are out there for breast cancer. If they don't, or or feel that you're kind of on the fence with possibly being greater than 20%, they can send you to a high-risk place. And like here at the Ohio State Hospital, we do high-risk screening, and so you can come in, you can meet with a physician, they'll calculate your risk and let you know if you do need supplemental screening. So that's two different ways to find out about that. There's no study to date showing benefit of supplemental screening with MRI with a 2D mammogram for women with dense breasts that are in the lower intermediate risk. So studies are still happening for that, but there's nothing that's come about that shows that that's a benefit as of right now. So this is an example of an MRI. This is looking at the breast from the side. Here's the nipple, and all these blue arrows are kind of pointing out all this white, kind of bright areas here. This is called enhancement. This is what we look for on MRI after we give you the contrast. And over here you see some more enhancement in a mass kind of formation. These are the things we're looking for in the breast. It has to be more than the background. Here's just regular breast tissue. You can see this lady has a lot of breast tissue in here. All of this is breast tissue. So it's very dense. And on here, yes, she has some concerning findings that are enhancing, but the background area is not, which, you know, on some women with very dense breasts, we don't get a lot of background enhancement, so we can see through the breast very nicely, and the only things that enhance are things that are concerning. So this is an example of what an MRI looks like. MRI is great. The only problems we have sometimes with MRI also is if, you know, women who do have a 20% or more lifetime risk who want to undergo supplemental screening with MRI, couple things that can sometimes be a problem is if they're claustrophobic. A lot of people don't handle being in the magnet that long. It's about a 30 to 40 minute test. You have to lay super still. You know, get contrast, which is not a problem, but a lot of people don't like the idea of getting contrast. They don't like the claustrophobic feeling of the MRI and the length of time they have to lay still in order to do the exam. So sometimes those are, you know, negatives for people for utilizing this study. So another supplemental screening that's out there is called molecular breast imaging, or MBI. We do not currently use this, but it is used at a lot of other places, including the Mayo Clinic. It does have higher radiation exposure, so it's about 3 to 4 times the radiation exposure than the 3D mammogram. Currently, as far as I'm aware of, there is no biopsy capability, so if you find something on this and you go try to find it with mammogram or ultrasound or MRI and you can't find it, you're not able to biopsy utilizing this specific modality. Not that a lot of people will have a molecular breast imaging finding only, but it does happen sometimes. So that's a kind of a downfall to the test as of yet, but I'm assuming that they're probably working on a biopsy capability. It's a lengthier test. It takes about 90 minutes to complete. And the other thing is when we do molecular imaging, we inject the radiation isotope into you. So it's going through the bloodstream and it goes to the breast. However, it also goes to, this particular isotope goes through the parathyroid gland, the thyroid gland, the heart, the liver, the colon. So it does expose other organs in your body to radiation for a longer period of time than just a mammogram or which is just an X-ray. So this particular isotope has a 6-hour half-life, which means in 6 hours the dose you got will be cut in half. In 6 more hours, that half dose will be cut in half, and then another 6. So it takes about 24 hours for it to really be gone out of the body. So this is an example of what a molecular breast imaging test looks like. This is the mammogram here, which has obviously got some dense breast. And this is a molecular breast imaging study, which shows this black dot here, which is telling us there's something there, which would probably equate to something around here in the mammogram. And that turned out to be an invasive ductal carcinoma. So if you find out that you have dense breasts, what should you do about that? Continue to get your annual screening mammogram, because as I said before, mammograms have been the only modality shown to decrease morbidity and mortality. Talk with your primary care provider about your risk factors and if supplemental screening is necessary, and find out if you are over that 20% lifetime risk. And if you have tomosynthesis offered wherever you get your mammograms, then make sure you ask for that, because that will help the radiologist be able to see through the breast in a 3D image and help find any kind of underlying masses and decrease that masking effect we discussed. These are the references that I utilized for this presentation, and I'll take any questions if anybody has any.
Thank you, Dr. Kerger. We do have some questions coming in. One
Okay.
question is, I had a double mastectomy. The surgeon who did the mastectomy and the surgeon who did the reconstruction both told this person that she no longer needs any mammograms. What is your opinion on that?
That is correct. After mastectomy, no mammograms are needed. Most of the time with people that have mastectomy, we just do clinical exams, so palpation, and then if anything's found, we can use ultrasound or MRI to evaluate that.
Okay, thank you. Why would one choose a molecular breast imaging over just an MRI with the difference in between each? What would make one choose the MBI?
That's a good question. So for MRI, like I had mentioned, some people are claustrophobic, and the molecular breast imaging, you don't have to go into any tube or anything. It's set up kind of like a mammogram. So that's one thing. The other thing is there are people who have certain types of pacemakers and certain implants and certain stuff they've surgically had done to their body that we can't put in the magnet. That's becoming less and less with time because now they're making a lot of those things to be able to go into the MRI magnet. But if someone has something like that, then the molecular breast imaging would be another reason, or it'd be another reason to use the molecular breast imaging.
Okay, thank you. Another question, if you've had biopsies before and they've been negative, and you go every year for your mammogram, and it doesn't show breast density, is there a point in time though where you might want to ask to have a supplemental screening because of previous history of having to have biopsies?
Previous history of multiple biopsies does increase your risk for breast cancer. That is a risk factor, even if they're benign. So it is something you should discuss with your physician, and also see if you can find out what your if you're in a state where it's not telling you whether or not you have dense breasts, and kind of ask your physician. Should be able to look up the radiologist dictation and see what breast density they gave. So if you are in that heterogeneously dense or that extremely dense category, they should be able to let you know that. And then, if you're really concerned, you can look around and see if anybody does have tomosynthesis available for their screening. Like I said, more and more places are getting that currently. And that would be a really good way to just help you not maybe get called back for a lot of needless biopsies, to be able to look at the breast in that 3D imaging. And that supplemental screening, like I said, is covered by insurance companies a lot of times, and if it's out of pocket, it's not as big of an expense. So, and most insurance companies are covering it even if you aren't at a higher risk.
Okay, thank you. What about men? We know that men have breast cancer as well. Do any of these specifics also reflect on men? Do they get dense, do they have mammograms where there's dense tissue, or how does that work?
No, men don't have dense breast tissue. Men have ducts, but they don't have the terminal lobular units, which make the milk. And the ducts really don't add a whole lot of density to the breast. So most men, if they have a palpable abnormality and they're over the age of 25, we do a mammogram. If they're under 25, we do an ultrasound. And the mammogram is usually more than enough to evaluate a man's breast.
Okay, great. Okay, well, those are the questions might still be coming in, and we will make sure that we get those over to you to be answered.
Wonderful.
And we thank you for your time. This was a great presentation, and your message is so appropriate with October being Breast Cancer Awareness Month. So thank you very much.
Well, thank you for having me.
Well, we're glad you were able to join us. And we appreciate everyone joining the webinar. And as a reminder, if anyone still has questions for Dr. Kerger, please send them to questions@mycancerbridge.com. And again, look for an email when the webinar recording has been posted to YouTube. So thank you, everyone, and have a great day.
Thank you, Cindy.
Thank you, Dr. Kerger.
Bye-bye.
Bye.